Okay, I am very pleased to move on to our next session. Our next presentation is called "What is my doctor thinking? A clinician's approach to weight loss treatments" with Dr. Ian Rigby. Dr. Rigby is a physician and clinical associate professor at the University of Calgary. He practices emergency medicine at Foothills Medical Center and obesity medicine at the Alberta Obesity Center. He comes to our conference today with both clinical experience in treating patients for weight loss and as a person with lived experience of spinal cord injury. And I'm really pleased to welcome you to our weight management forum, and thank you for taking the time.
Awesome. Thanks, Jocelyn. And nice to see you again. It seems to have been a while. So,
Yeah,
and thank you to everyone for taking some time to join us this afternoon. I won't repeat what Jocelyn said, but I am a physician here in Calgary and work in obesity medicine. I have a spinal cord injury. So all sort of reasonable reasons why I think always entertaining to chat to this group. So hopefully that looks okay to everyone. Maybe I'll trouble for a thumbs up or something. Yeah. Okay, excellent. So as Jocelyn mentioned, my name, what my talk today is on: what is my doctor thinking? And, really my hope for this afternoon's chat is to really give you guys a little insight into what your physicians think about when you do go to them to talk about weight loss, and really to kind of understand the structure of their thought process, so that kind of what kind of treatments are out there and what sort of treatments they might be recommending for you and how they're sort of thinking about that. So that's kind of the inside baseball of today's chat. Before I begin, I would like to say, though, I am going to be using the term obesity in our talk this afternoon. Obesity is one of those words, of course, that I actually don't use with my patients or people I talk to. We talk about excess weight and weight loss, but it is really definitely, it's in the textbooks. It is the way all our medical associations define things. It's how our treatment plans are defined. So please understand, when I say obesity, it is not meant to be hurtful or the like. It is just helping you kind of understand where your doctors are coming from and why they might use that term. So and just prior to getting started, always worthwhile wondering, how your presenter's bread is buttered and if they're coming to you with weird and wonderful stuff. And to make a long story short, I have no conflicts of interest. I make my money treating patients and from the University of Calgary for some teaching, but Big Pharma has not driven any dump trucks of money up to my door, although I'm totally open if any of you know that. But pretty much everything I'm going to tell you this afternoon would be thought of to be pretty standard medical practice. So with that said, what are we going to chat about? I think really kind of three goals, if that's all right. The first one, really, I'd love to spend just a moment or two defining overweight and obesity, mostly because this is what your physician is going to do in the clinic, and really leads into what sort of treatments we are going to think about offering for you in terms of weight loss. So I think a couple moments there would be great. And then maybe just a moment to say, well, why on earth do we treat obesity? So, I've got this clinic I work at, the Alberta Obesity Center. Why do we spend all this time and effort to work around obesity? What's our goals? So I think those two will be short. And then really to help you understand the treatment approach that we think about when we think about weight loss and treatments therein. So that's what we're going to look at. The definition, this is straight out of the textbook, right? So obesity, it's a prevalent, complex, progressive, and relapsing chronic disease characterized by abnormal excessive body fat, or adiposity as we call it, that impairs health. And I think there's really two key pieces to the definition that are useful to think about. The first one is just prevalence, right? So if we look at the last good data I have from Canada is about 2020, and it would actually say that 36% of all Canadians are actually overweight, and 25% would be what we would call obese. So this is 60% of adult Canadians. So this is really, really prevalent, something we see on a daily basis for sure. And then the other part of this definition that I think is really useful is that our opinion on being overweight has really swung in the past decade or so to really recognize that this is a chronic disease. This isn't just excessive overeating. This is a host of challenges right from genetics to neurohormonal aspects to our nutrition to our activity. It is very complicated. It has a whole bunch of moving parts to it. And it's not just that you eat too much, which unfortunately is still in some of our physicians' minds. So just to say, that's our textbook definition. But really where the rubber hits the road in the clinic is how do I define this clinically for my patients? And we really use two measurements to screen for obesity. One is the body mass index, and the second is our waist circumference. And I'll talk briefly to those because particularly in our SCI population, there's some pros and cons around both of these sort of issues. So the body mass index is pretty easy math. So we just take your weight in kilograms, we divide it by your height in meters squared. And what you can see on the slide there is sort of our normal, our overweight, and then our obese ranges. But this is really just a screening tool, right? So first of all, these numbers are really generated in a healthy Caucasian population. Certainly there are different numbers for people of different ethnic backgrounds. And second of all, as you can imagine, this is a challenging thing to measure in folks who have an SCI, right? So I don't remember the last time I actually was able to get on a scale myself as a physician to figure out what my weight is, and let alone my height. I guess we could do it if I laid down on the couch or the bed, but not an easy measurement for sure in our population. So a few caveats there. And then secondly, with BMI, it also over and undercalls a number of people. So if you imagine the competitive bodybuilder who's got giant muscles, may weigh a whole lot, but has almost no body fat, you can imagine that this person could, by BMI standards, be called obese, when in fact they have almost no body fat. So they're clearly not that. On the flip side, BMI also undercalls obesity in those of us who have less muscle mass, right? So this is something we do see in our SCI population, where because of our neurological injury, our denervation, and our loss of muscle mass, we actually can be found to look low or normal weight when really we might have extra amount of adiposity. So BMI is just a tool. The second measurement, and probably more useful in the SCI population, is our waist circumference. And this is really the sort of number of centimeters around your waist, measured right at the level of the hip bone. For people who are able-bodied, we do it standing, parallel to the floor. In SCI, we can do it laying down and basically perpendicular to the floor. And some reasonable studies that would speak to the fact that a measurement of over 94 centimeters would put you at what we would call high risk for obesity, meaning increased risk for the cardiometabolic diseases that happen with obesity. So, that is derived on some small patient populations, but probably some of the best literature out there, and I'm sure a number of you have run into it, but would certainly be the measurement we would use for a person with SCI in our clinic. Yeah. So with that being said, it'll become obvious how we use much more around BMI in a moment or two around the treatments. But that's really where your physician is going to be thinking in terms of, okay, are we going to be escalating our treatment above some of our more just sort of standard approaches? So, and then why do we treat obesity? Just before we move to the actual treatments, as you know, basically our goal in medicine, we want to really improve, healthy life. We want to prevent and minimize the suffering from medical complications. And the unfortunate truth is really obesity negatively affects pretty much all aspects of our life. If you think about mental health, it's certainly associated with a number of increased disorders, depression, a lot of the mood disorders. From a biomechanics point of view, certainly we see lots of earlier osteoarthritis, and for sure in our population, challenges with transfer, challenges with skin health, very common. And then almost any organ is affected by obesity. As you can see on our slide here, the diabetes, high blood pressure, heart disease, all of these are affected by being overweight. So if we can actually treat that, we can prevent the downstream complications of it, minimize the challenges of that. That's really our goal. And as we head towards treatment, I do want to emphasize one thing. So in the clinic, I do have lots of people come to me and they say, you know what, Ian, I want to lose 50 pounds. I want to lose 100 pounds. And that might be appropriate for folks. But the physician in me knows that, even a fairly moderate loss of 5% of your body weight has immense positive changes on your either management of your health conditions, say diabetes, high blood pressure, etc., and also markedly decreases your risk of developing those. So if you think about that, if this is, let's say, a 200-pound person, 5% is a 10-pound weight loss, which, isn't shockingly large, but what it does in terms of modifying your risk for disease is quite marked. So although it may be appropriate to be talking about these large amounts of weight loss for folks, from a medical point of view, even fairly modest amounts can make big differences. So even though we're going to go into some of the more aggressive treatments that are out there, would really urge you to bear in mind that it doesn't take big changes to really improve your health. So having said that, what are the treatments and how is your doc going to think about this? So when we think about treatments, we're really thinking about, first of all, kind of what our weight loss goal is. How much, are we looking to lose to get us to a healthy weight, to prevent complications and challenges? And, the cornerstone of our treatments are a lot of what you guys have talked about over the last couple of days, right? And for the physician, I think about this as lifestyle modification. So this will be, nutrition, physical activity, behavioral, what we think is behavioral medicine or changes, and then of course, changes in sleep. And this sort of cornerstone stuff, you can spend days talking on every aspect. I will highlight a couple of pieces here as we go forward. But, all comers, no matter how aggressive we want your weight loss, we really need to start at this part of our pyramid. The next step really is if we decide that we want to move a little more aggressively, we need a little more weight loss to improve your health, we start talking about some of our really prescriptive nutritional interventions. For us, that would be things like intermittent fasting, could be some of our commercial programs out there, the Weight Watchers, Jenny Craig, things like that. And then the one I will particularly talk about here briefly would be around some of our meal replacement therapies, as we've got lots of good data to say that approach certainly can make quite a significant difference for folks. So I'll touch on that shortly. And then as we go further up the ladder of treatment, we start to talk around medications. And at this point, we're really now starting to balance the side effects and costs of our intervention, so drugs that we're going to talk about, with really the potential gains of reducing weight. And so as we'll get to in a moment when we talk about meds, at this point, we're really looking at people whose BMI is over 30, or they have a BMI over 27, and really another weight-related medical disorder, high blood pressure, diabetes, that sort of stuff. And at that point, we think the balance of, cost and side effects of medications and what you can get in terms of health improvement with weight start to come through. And then last that we're going to talk about, if we need to be even more aggressive in the weight loss, we're going to talk about the surgical options that are out there and some of the common surgeries that happen for weight management. And again, as you can imagine, surgery for weight management, more aggressive, more risk of complications, side effects. So we need to balance that with the health benefits we think we're going to get out of that weight loss. So that's kind of our journey we're going to chat about here in the next few moments. And I'm going to start really briefly with sort of the physician's take home, I guess, around nutrition. You guys just had some great nutrition talk, and I think there's no question we could spend days talking around nutrition. It's complicated, it's quite individual, and the science is mixed at some points. But I'll give you what I think the physician's take home would be for it. And the first question I get usually when someone comes to our clinic, they say to me, Ian, what's the best diet I can be on to lose weight? And the truth of the matter is, when you look at our literature around, the classic, whether it's low carb, low fat, plant-based diets, Mediterranean, et cetera, they're all fairly equal in terms of weight loss, right? So there probably isn't one that I'm going to lean to just in terms of weight loss. Having said that, things might change depending on what we're treating folks for, right? So if you have very challenging diabetes to control, there certainly is a nutrition approach I'm going to lean towards for you. If we're looking at high blood pressure, or your cholesterol is very is very high, certainly there are specific nutrition approaches will go there. But really, no one approach is really going to be best for weight loss. And that's probably because as humans, I mean, we're really adaptable in terms of how we get our energy sources. So the body can run well on all sorts of energy out there. So the take home from that is usually the best nutrition approach is really an approach that you as an individual can stick with long term, right? We're looking to really develop long-term healthy approaches to nutrition. So case in point, if you come to the clinic and you have, let's say, ethical or religious reasons that you don't want to eat meat, I should probably not push you towards a carnivore diet. You're going to have some very fancy words for me that are not very nice. And so we need to try and tailor an approach to, a good diet that is sustainable for you. Having said that, as a physician, the diet I know that does not work is the pizza and Pepsi Cola diet, unfortunately. And I think the one thing that all of those other nutritional programs are good for is they minimize processed food. And I think some of our best science would say that the minimization of processed food is really key in a successful nutritional approach. So if whether you're doing Mediterranean or plant-based or low carbohydrate, really getting away from the processed foods is going to be key to successful weight loss. Years ago, the theory around nutrition was it's calories in versus calories out. And we certainly know that that is probably a very simplistic approach to weight loss. But having said that, you still do have to run a bit of a calorie deficit to lose weight. In our clinic, we usually start looking for about a 200 to 500 calorie a day deficit in your approach. We have had people who come to us and they say, Ian, I've made a very successful transition to Mediterranean diet, but they're eating 3,500 calories a day in Mediterranean diet and not losing weight. And you're like, I think I've got a first idea of what the challenge is. So we do still have to run a bit of a calorie deficit, even though that is, 200 to 500 calories is an individual starting spot. And we're going to basically adjust based on people's response. The one thing, though, that I have found very useful is certainly recommending diets that have higher protein. So we do look for sort of the 1 to 2 grams per kilo per day of protein, really for two reasons. Number one is the increased protein that we have really works well to basically decrease our hunger and our cravings. So certainly really helpful to keep away from the snacking and other challenges. And second of all, some increased protein definitely helps us to maintain our muscle mass while we're losing weight. So love to have a bit of extra protein there. And finally, and this is probably a great take home for us physicians, is it's easy for me to say, look, we're going to do a certain nutrition plan and a certain calorie count, and it all sounds great. And then when you get off the discussion from me and you go home, you're like, well, how on earth do I do that? And so we physicians are somewhat horrible about making that transition from sort of high level approaches to what your daily meal plan looks like. So I would say, don't be afraid to involve our dietitians, our nutritionists. This is an area of their expertise, and we really need to lean on them for this, because that transition to a daily eating plan is where a lot of this falls down, particularly if you're getting advice from a lot of your doctors. So I think that's kind of big picture what I'll say around nutrition. Don't want to really belabor that because I think we have some other more medical stuff to get to yet, but we'll be happy afterwards to chat a bit about that. I do know that you've had a discussion around physical activity earlier in the conference. And again, I won't sort of belabor this much, but maybe give you the highlights of our guidelines that we will use. This is not specific to SEI. This is in the able-bodied population. First of all, of course, any activity is better than none, right? So I certainly do have lots of people who do come to the clinic and they say, well, I'm only walking a couple days a week. I'm like, that's perfect. Just do that, right? I mean, that's super useful. Our guidelines around aerobic training, 150 minutes a week of moderate physical activity. So for those of us in chairs, that might just be pushing. For people who are able-bodied, that would be just, easy to moderate walking, or 75 minutes a week of really vigorous activity. So whether that's, your wheelchair basketball, rugby, hand cycling, whatever that case may be for folks, that's the aerobic training guidelines. And then really to try and keep our muscle mass up, sort of 2 or more episodes a week of muscle resistance training. Again, trying to keep our muscle mass up works well to burn calories. Obviously, very important in the function that we have as people with SCI. But I go back to the whole take home at the end there. Any is better than none. So that's physical activity in our lifestyle modifications. The third part, and I know this was also talked about earlier in the conference around behavioral modification, and that losing weight really involves changing eating habits, changing activity patterns, changing a lot of the behaviors around eating. And we really come to realize that if you don't address those behaviors, we're probably going to fail in all this. And in fact, at the clinic, we have 3 teams. We have a nutrition team, a medical team, and a behavioral medicine team. And I think we spend probably more time in the behavioral medicine aspect and behavior change than anywhere else. So really a successful program really should give you an ability to build some goals, give you some support, develop some feedback. And there's lots of ways to do this. I know you've heard some earlier on. Our clinic, we use a sort of a cognitive behavioral therapy approach to it, but a successful program will help support you in those sort of changing behaviors. All right. Next up the ladder, as we talked about in terms of treatments, that baseline is what I think all your physicians will talk to you a bit about. I know we didn't touch on sleep, a whole different matter. We can talk that if you want. But the next step up, we talk about prescriptive nutritional interventions. These, again, could be intermittent fasting or time-related eating, some of the commercial programs, Weight Watchers, Jenny Craig, et cetera. And the one I did want to mention here really is around meal replacement therapy. And so meal replacement therapy really is a situation where we generally would replace 1 or 2 of your meals in a day with, usually it's a shake, sometimes a bar. And so these are specifically formulated products that give you sort of dense nutrition, good calorie control, good improved protein. And the studies here are very supportive of doing this. I gave you the picture of OptiFast because it's one of the ones we use a lot, but there's 4 or 5 good ones in the market, Robard or Optiva or Bariatrics. And these, I think not only are they good nutritionally, but they're easy, right? So if you've got to go somewhere and you need a lunch and the lunch you're bringing in is a shake, that's a whole lot easier than a bunch of really complicated meal prep. And so I think that's a combo of good nutrition and ease is part of the reason why meal replacement is super useful and we use for lots of folks. So something to think about as we move up our sort of interventions. And the one thing I do want to say around meal replacement, we do sometimes use complete meal replacement, where we basically replace all the meals you eat in a day with these sort of shakes and the like, with a little bit of maybe some vegetable stuff every evening. We do that for specific medical conditions, usually prior to a number of operations and the like, where there's going to be big benefits to it. And I just want to say that if we do go down that route, it needs to be medically supervised. You can get into some little trouble with doing this. I've had a few patients come to the clinic who, on our first chat, said they've decided to do this and they pick up a protein powder from GNC, and now they're in all sorts of trouble and can't figure out why they got tremor and their hair is falling out. I'm like, oh, stop. We need to reevaluate this a bit. So just to say that if you suddenly find this working, but you want to get rid of all your meals, please talk to your doc first. So they could be fraught with a little bit of a challenge there. All right. Third up our list, the medications. So at the point where we start talking about weight loss medication, we're now really saying, okay, we're entering a realm where the potentials for cost and side effects are going up. But having said that, we are really concerned about the downsides of the excess weight that a person has. And so we're going to really try and balance those two out. In the literature, we usually start thinking about talking medications when a patient's BMI is over 30. So this is, remember back when we would talk about people who by their clinical definition would be obese, or they're over 27 and they have a weight-related other medical disease, right? So high diabetes, high blood pressure, et cetera. And this is where we think that probably that risk-benefit ratio starts to lean towards medications a bit. And this is very individual. It does not mean that if, let's say, you have a BMI of 30, you have to be on medications. These are a tool in our toolbox. There's no right or wrong time to start them, but this is when we would think about chatting with you about medications. And really, in the medication space, there's really 3 classes of Health Canada approved medications in weight loss, and this is what we would use at our clinic, and I think what most of people's physicians would know something about. The first ones are called our GLP-1 receptor agonists. And of course, they never let us use words that sound anything like English. So liraglutide, semaglutide, all that sort of stuff. If you get any sort of American TV, you've probably been beaten over the head with those Ozempic ads. It seems to be everywhere these days. But that is one of our GLP-1 receptor agonists. And so these are medications originally used in diabetes that we do use in non-diabetic population these days, and works really well insofar as it decreases appetite. It increases your feeling of fullness early when you do eat, so helpful for portion control, and decreases the amount of insulin we secrete when we eat. So it helps with a bit of the weight loss or the weight gain that we do when we eat. So kind of all 3 mechanisms here. And as a class, these are probably the most effective of the medications that we have. So certainly we do use them lots. The part that makes what's left of my hair fall out is trying to get insurance coverage for patients and the like is really tricky. A lot of the insurance plans do not cover these. So it sometimes just, causes me more than a little bit of grief. The second agent that's out there that is Health Canada approved is a medication called Contrave. And Contrave is a mix of 2 medications, bupropion and naltrexone. So one is an antidepressant, one is an we call narcotic agent, meaning it reverses narcotics, but together they work really on the craving centers of the brain. So what we find is that, lots of folks will come to the clinic and they'll say to me, what, Ian, it's really interesting. What I'm finding derailing my progress is not hunger and appetite, but it's actually cravings. I might finish a meal, I might feel full, but I can't stop thinking about the cookies, the potatoes, whatever the case may be for folks. And if they find that is the real struggle, then I will think a lot around Contrave as a medication to try for folks, in that it helps a lot around the cravings. So these 2 classes are probably the ones we use the most in clinic. The third one is a medication called Orlistat that has been around for a long time. It came out in the early mid-80s. And its mechanism, it really works to decrease fat absorption in the gut. So you eat the fat, it blocks the absorption. And so it doesn't come in, you don't absorb those calories. From a point of view of weight loss, certainly works. The problem with Orlistat is, unfortunately, when you eat the fats and it doesn't get absorbed by the intestine, it goes right out the other end of the intestine. So causes all sorts of trouble, gut grief, cramps, diarrhea. What I usually say to my patients is any medication whose side effect is anal seepage, we might want to think closely about before we utilize that. So definitely one that we occasionally use, but with a bit of caution. And then, just to be honest, there are a number of others that we utilize off-label. There are some diabetic medications we utilize in specific circumstances. There are some to be aware of in the US that are not here in Canada. Some of the stimulants, phentermine being the classic, that are just not there. And then a number that are up and comers. I think a whole pile of my patients are certainly on me about when tirzepatide, one of the new anti-obesity medications coming to Canada, not here yet. So just to know, there are some other ones, and depending on other medical conditions, we may employ other medications there for folks. So that would be the medications. And then finally, just being cognizant of time, if we really feel that the downside of the weight and excess weight people have is really markedly impairing their health, and we've been addressing everything else, through these other aspects of the pyramid, we're going to talk about surgical intervention for folks. And once again, not to say that if you have a BMI over 40, you need surgery, but that is the time when we start to think the tool of surgery might start to, outweigh the risks of the, the excess weight. So in terms of surgery, I will probably mention three surgical approaches that we talk about. One in so far that it's talked about lots, but we don't do any longer. And then two other surgical procedures that are the sort of bread and butter of our surgical approach. So the first one here is called the gastric band. And the gastric band, just to orient you a bit, at the top here is the swallowing tube. This is your esophagus. This little guy here is your stomach. And then it goes out into your small intestine down here. And the gastric band, what a surgeon will do is basically they put a little cuff around the top part of your stomach. That goes to a little cord that goes to a port that sits just under your skin. And with that port, the surgeon can inflate or deflate this cuff with a bit of sterile water. It's been around for quite a long time, but it actually is a procedure we don't do anymore. Unfortunately, what we found is at about 5 years, we had to take almost 40% of these out due to complications. And so although it's in the literature a lot, lots of people still have them. Most of our surgical programs won't put the band in any longer just due to those complications. So having said that, the internet is awash in the gastric band. Lots of new patients come into our clinic, want to talk about it. It's the idea was fantastic. It just in real life ended up not working as well as we'd like. The procedure that is done the most surgically is called the gastric sleeve or the sleeve gastrectomy. And then just orient yourself again. This top part here is your swallowing tube. This would be the stomach. And then this goes out through your small intestine. And really what the gastric sleeve does is basically they take the outer 2/3 of your stomach basically off and turn what's left into something that's shaped pretty much like a banana. So it basically works in two ways. As you can imagine, you have a much smaller stomach so that when you do eat, you get full a lot earlier. That's the restrictive part of it. And then the surprising part is actually comes from sort of the hormonal effects of this surgery. Insofar as one of the hormones that really controls our hunger and appetite called ghrelin is made a lot in this portion of the stomach that we take out. And so what tends to happen is not only do you have this restrictive effect of a stomach that is much smaller, but actually your appetite markedly goes down because of that hormonal effect of this part being gone. So this is probably the surgery we do the most here in Canada and in the US. It has quite a low complication rate. It's got all sorts of ways that it can be fixed if there's trouble. So it is the one the surgeons will lean to most often. And then finally, the other one that's certainly in the literature lots, and we see lots, and I see lots at the clinic, is called the gastric bypass. And just to orient you again, this top part, the swallowing tube, your esophagus. And then what they do is they take a small bit of the stomach out and then take a piece of your small intestine, that small bit of digestive stuff, and come up and to attach it to this last piece of the stomach. So really what's happening, your food comes down here, sits in this little top part of the stomach that's left, and then bypasses all of this into the small intestine and goes down. And then this is reconnect your stomach, what's left of your stomach and the like is all reconnected downstream. So really you now have a really tiny, tiny bit of stomach, and then you've bypassed a bunch of the digestive aspect of your stomach and some of the small bowel. So this leads to greater weight loss. Certainly, as you can imagine, you can't eat a whole lot at a time, the restrictive effect. And it also, interestingly enough, has a really impressive change in some of the hormones that control your eating. In particular, for these, the GLP-1, which is that type of medication blocker we talked about, it really changes markedly. So both of those really cause an effect here. As you can imagine, this is a bit bigger surgery, a bit more risk of malabsorption. So is used really if we need a lot more weight loss or have really complicated challenges to control like diabetes and the like. So cognizant of my time, I'm running a couple minutes over. Those are sort of our surgical approaches. And so what did we talk about today? Really wanted to spend a few minutes defining how your clinician or your doctor is going to think about overweight and obesity how they define it, and how that leads into the types of treatments they'll recommend. A quick thought about why on earth do we even treat obesity? What's the point of it? And then this is the sort of stepwise approach that your physician's going to think about, going to talk to you about, and that hopefully you'll encounter if you or your loved one's going to chat about managing weight. And with that, I will stop my sharing and would be happy certainly to try my best to answer any questions.
Amazing. Thank you so much, Ian. That was like full of so much great information, and I think a great way to kind of summarize what we've all learned throughout these 2 days, I hope. I'll just open it up for questions, but maybe I don't see any hands or anything in the chat at this point, but maybe I'll ask the first one. Do you know of some specific common SCI medications that could contribute to weight gain?
Yeah, great question. So one of the things, and I didn't get into this because it is, I guess I don't think of it as a treatment, but a screen. There are a number of common medications definitely related to weight gain. And so the ones I look at in big classes, the first one would be, I always think of my antis. So the antidepressants, of course, very common, and quite a number of those will cause weight gain. So that's my first go-to. And there's probably a half dozen that cause weight gain, some that are neutral, and bupropion or Wellbutrin is probably the only one that is okay for weight loss. I think about our anti-diabetics. So I heard earlier a question about around insulin, and 100% insulin is one of those medications that if I can keep my patients off insulin, that would be lovely because it does promote weight gain. A couple others are notorious. Some of the ones called our sulfonylureas, like gliclazide, I try and avoid if I can. Sometimes you just have to be on them for actual, sugar control though. So it's a bit of a balance. Our antipsychotics are pretty common troublemakers for us too. So I'm thinking of all those antis. And so those would be some of the big ones for sure. Some of our neurologic pain medications are also implicated. So yeah, so there's a wide host. And as part of going to a physician around weight loss, asking to have a chat around, do any of my medications give us this trouble is super, super useful.
Go ahead, Jolene.
Well, thank you very much, Terry, for asking my question. And I love the title of this. I think it's just been a wonderful Friday and Saturday and to help me. So when I saw the title is What is my doctor thinking? I gained 85 pounds on gabapentin. Yeah. And for every 100 milligrams, I gained 10 pounds. And not changing my diet, not eating more, not anything. If I stopped taking 100 milligrams, I would magically lose 10 pounds. And I always say that gabapentin and baclofen are perhaps the solution to world hunger,
Yes.
So I've managed to lose over half of that weight, but I eat less than 1,200 calories a day. So, and I know this happens with quite a few people where we need these medications for neuropathic pain. And so I thank you for your title, because whenever I've mentioned this to my doctor, he says, well, don't complain about your weight gain because you take baclofen and gabapentin, you just have to live with it. So I'm very thankful for everything that everyone has offered today, because especially the part about inflammation, that maybe I can reduce the inflammation, which is increasing the neuropathic pain, and then I can reduce my gabapentin, and for every 100 milligrams I'm going to lose, I can lose 10 pounds. Do you realize I'll be able to lose 40 pounds and eat more?
Love it.
Yeah.
Love it. Yeah.
Thank you so much.
Oh, yeah. And you know what, a good resource, I do find there's a group, and you probably all have experienced this. Some of the physicians are very facile around weight loss and looking for medication challenges. Others, it's a black hole for them, right? And it's part of our training. I don't make an excuse for it, it just is. one of the resources that is useful for folks, if you're wondering if you're in that circumstance, the Obesity Canada website has a series of guidelines, one of which is around medications in weight gain, and they have a table that basically outlines the real, troublemaker medications and a number of alternatives people could think about. This is actually something that is well referenced in the medical literature. And if you have one of those physicians who, unfortunately, this is not their area of expertise, even bringing that into the clinic and saying, hey, can we talk about this? Can we minimize, if I have to be on some of these, can we minimize them, or are there alternatives? Is a super useful discussion. And those Obesity Canada guidelines they're accessible to everybody. So yeah, super useful, because every now and then, yeah, we physicians sometimes need a little prod to kind of update our knowledge.
What about in your clinic, in the obesity clinic, what would you say is the percentage of people that have just great success with like lifestyle changes versus the other interventions?
Yeah. So I think, my experience would be similar to what I put up on that sort of diagram, in that, if what you're looking for is, that around 5% sort of change, that's sort of the average. Now, some people do fantastic. They can do way more. But that would be sort of an average with lifestyle modification. Like, sometimes we find, yeah, you come across a medication we can change, et cetera, et cetera. Now I'm going to caveat that with, in the clinic we work at, probably 2/3 of my patients have what we call surgical obesity, meaning they've already had a bypass and they've unfortunately had weight recidivism. They've regained weight and we're back to that. So I'm probably not seeing the average population, Terry, but having said that, I would say with that whole approach, spending a lot of time on those basic interventions, and then thinking about, do we need to, do some meal replacement? Do we need to think meds in particular? Those three levels, I would say 2/3, 3/4 probably do super well, at least, yeah, over the course of even a year. So I think it is pretty successful.
Another question kind of about lifestyle change, because, and I'll show you guys at the very end that slide also about the weight management program that's going to be starting, but that's kind of the whole idea, is to encapsulate all of those different interventions around lifestyle change, and help you, right, with all of those pieces. But in your opinion and what you've seen, it doesn't necessarily even have to be weight management specifically, but I think, and a lot of presenters have kind of talked about this throughout these last couple of days, about compliance, right? Like how hard, like it's kind of easy to make the changes and do something for a little while. And then it seems when you're on your own and you need to continue, we just fall back in our old routine, right? And it's just so easy to do, even though we have seen the success of what it can do, right? And we've talked a little bit about, adding in cheat days or whatever. But anyways, what are some suggestions that you might have for, continuing on and keeping motivated with what that works?
Yeah, I mean, that's the, as much as the physician in me likes to say, oh, med, surgery, all that magic, I honestly find that probably the most powerful piece of the program I work in is around the behavioral medicine bit, around change management. And my experience has been that the people who do really well just continue to check in. We're lucky that our program runs for as long as it, people find it useful for them. So that's really nice. And just the recognition that sometimes life happens and you kind of fall off. There's other priorities that are important, right? And then that what matters probably most is not that it happens, because it does all the time, but that you kind of come back to it and you say, okay, look, I had a bad week, a bad month, whatever that case may be. You touch back in, you sort of revisit the goals, get back on that horse and go again. So I think the take home I have from most of the people who I see who have been very successful in the clinic is they don't just they're okay with it when things occasionally fall apart. They come back to it. don't beat yourself up too hard around that. That happens to all of us, no matter how much education, willpower, et cetera, we think we have. Is there's just gonna be times when that's not gonna be a priority in your life, and just understand that and come back to it.
How long would a typical patient be in your clinic for? How long do you kind of follow through?
Yeah, it's a great question. So right now it's pretty variable. I think they kind of come into one of two things. The first group will come in and usually are with us for a year. And by a year, if they are having great success, they're medically stable, they seem to be on interventions that are working. Probably about half of those say, okay, I'm probably okay, and I'm going to step out. And that's great. And those would be sort of the new people to clinic. The people that we've gone through the process, they've had surgery, they've had weight regain, et cetera. A lot of those have been with us a couple of years now. And it's probably less about maximizing their medical therapies and the like, and a lot more around the fact that it's the feedback and the behavioral medicine team and the support that makes a big role. And, our vision for some folks is that's going to be a long-term thing. And I think that's unfortunately what our medical system is not great at, is providing that sort of support and recognizing how important that is. So a number of those, a good percentage of our patients, I think, are going to be with us for years, to be honest with you. And that's what our program is built for, because I think that's one of the keys to success.
Yeah, that's I think that would be really helpful for me for staying on anything I decide to change. Anyways, I got a little message from Alan in there saying, thanks to Jolene for comments about gabapentin. I stopped taking it because it made me nervous. Strange, I gained weight when taking it. Jeff, do you want to ask what is the time that you can be on Contra?
Contra?
Yeah.
Oh, great. Yeah. That's a great question. So in terms of medications for weight loss, first of all those ones that we would utilize have really good long-term safety data on. So I'm always very comfortable keeping people on the medications as long as they're not having side effects to give them trouble. The guidelines from Obesity Canada, the Obesity Medicine Association in the US, we all say that we should, for people who are successful on medications, offer it up as a long-term therapy in the same way we would treat high blood pressure or diabetes, et cetera. When I look at the literature around what happens with long-term therapy, what we see is, if you're successful on a medication and you come off it, probably around 2/3 of people will start to see weight regain, right? So, I mean, it's just biology, right? If let's say you're on a medication that really suppresses your appetite and that's helping you, great, and you come off it and the appetite comes back, it's hard to fight biology. So we see about 2/3 will get weight regain. But the flip side, what I say is, 1/3 of folks in that time have developed new routines, new habits. So really, once we get you to your weight goal, if we're using a medication, I really give you the option. And I sort of said, look, I'm super comfortable if this continues to be a useful tool, let's stay on it. If you want to come off it and try it and see how you do, that's totally reasonable. And we just know that if weight regain becomes a problem, we go back to the medication. So it's a bit of follow-up, to be honest with you. But the long-term safety is pretty well established.
Marnie.
I think one thing about having like that clinic or just, falling off, like I think one thing that really helps is just to have like a friend or someone that you're kind of accountable to, I wanted to ask a question more for the previous presenters, but you might be able to help. They mentioned this testosterone replacement therapy. Is that a medication? And is that also something that women can take to help with weight loss? Or
yeah, that's a great question. TRT is it's funny, kind of half the docs out there probably use it, half don't. So first part of the question is there's a clear indication that if we sort of measure your testosterone levels and the like, and they're low, which is actually probably more common than we think, then replacement therapy is probably good. I mean, that makes sense, right? It does help build muscle, it does all that sort of stuff. The tricky part is there are some physicians out there who sort of say, oh, well, even if your testosterone levels are normal, we're going to try it. That data is not so strong, to be honest with you. And I'm not quite convinced on the literature there. And then the flip side is with women, a little trickier because testosterone has a bunch of effects on women, basically, male pattern hair growth, deepening voice, all the sort of secondary male characteristics that happen. So we generally won't use that in women just because that, most people don't want that, understandably so. So, yeah.
Yeah. Thank you.
Yeah.
Go ahead, Jeff.
The other question I have, what's the difference between pregabalin and gabapentin? Does pregabalin cause the weight gain that equals to gabapentin?
Yeah, great question. The pregabalin is the pre part just means it's kind of a precursor, meaning it gets absorbed and then broken down into the active form. So it's just a little bit about how it works in the body. My kind of clinical experience, and I don't know the literature on this, Jeff, so I apologize, is I find that pregabalin's a bit better in terms of not putting on as much weight than gabapentin. But I do still find it problematic, to be honest with you. So it's not a weight loss version of it, unfortunately, but it seems to affect people a little less. So if I have my druthers, I will have you on pregabalin. But it's, would I bet my monthly salary that that's going to work? Not 100%.
Oh, Jolene has a question. I'll let Jolene ask.
Okay, just a real quick thing that maybe will help people with the information at the same time. I too had problems with that kind of gabapentin anxiety, and you don't feel like you can sit still. So I went and started fish oils because it was used for hyperactive children, and it really resolved that kind of fitfulness that I had with the gabapentin. So again, the fish oils are an anti-inflammatory. Thanks, bye.
Yeah, 100%. There's actually quite good data, not around sort of that restlessness feeling you're talking about, but pretty good amounts of fish oil in terms of reduction in cardiovascular risk is pretty well studied and pretty good. So when people say, "Hey, I want to be taking the fish oils," I'm like, "Go for it." Yep, that sounds great.
All right, good. I was just going to ask questions about specifically women when they're premenopausal or menopausal is a time when weight gain is, and there does not seem to be any amount of exercise or nutrition that seems to help. Well, I don't know. I haven't found it yet. And a lot of my friends are in the same place as me. So yeah. I know it's kind of like a bit out of the scope of what you're talking about, but any suggestions?
Yeah. No, I mean, so Terry, you're 100% right. And it is an impressively common frustration for women as they enter menopause. I think what's the honest answer is I don't think we have a good approach to it medically. I'll be totally honest. We can measure hormones and the like, but short of full hormonal replacement, we don't actually have a real treatment for it. So there's lots of weird and wacky literature about what you can measure and when and how. And it might just tell you that you're menopausal, but you probably don't need the hormone testing to tell you that. And then the next question is, well, what do I do about it? And I think the answer is just, I'm sure 50 years from now, the physicians will look back and go, those barbarians, they didn't know how to treat XYZ. But the honest truth is I don't have a great approach to that, Terry, and I don't think most do. And certainly, you talk to our endocrinologists about it, and I think they're stuck in the same problem. I mean, we go looking to see if there's something else, right? Is there another endocrine problem going on? Are there other things I can adjust? Yeah. But I don't have an answer.
Interesting. Yeah, that's okay. No, that's fine. I mean, it's kind of good in a way because I've talked to so many people about it and no one has a good answer. And I'm like, how could this happen? This has been happening for so many years. How could they not have any answer? But anyway.
Yeah, in the typical way of medicine, right? The white male has been studied a lot, and so have mice. But women, no, we don't do studies on women. Why would we want to do that? So that's thankfully getting better, but unfortunately that is true. So yeah,
still a long way to go.
Well,
thank you so much, Ian, for spending a Saturday afternoon with us. So appreciative.
My pleasure, guys. Thank you so much for you guys letting me come chat. I really appreciate it. hopefully your next chat with your physician, you've got some, an approach to think about. So cheers.
Have a great day.
Yeah, bye-bye now.